Good morning and welcome everyone. My name is Allison Hoons and I'm a knowledge broker at Arthritis Research Canada and a member of Arthritis Research Canada's Volunteer Arthritis Patient Advisory Board. Before we begin, I'd like to respectfully acknowledge that Arthritis Research Canada's headquarters are located on the stolen traditional territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. We express our deep gratitude to the keepers of the land. I'm thrilled to be your moderator for today's webinar and excited to learn from our expert, Dr. Choi, a rheumatologist who specializes in lupus research. Our patient expert for this episode is Philippa Mennell, a member of Arthritis Research Canada's Arthritis Patient Advisory Board. This webinar is part of episode 14 of the Arthritis Research Education Series, Lupus-under-the-microscope, which features innovative research, including biomarkers and machine learning, focusing on understanding how lupus develops in the body. If you're joining us for the first time, the Arthritis Research Education Series was created by our Arthritis Research Advisory Board. The purpose is to share specific examples of research currently underway at Arthritis Research Canada and how this research can impact the lives of people living with arthritis. Today's presentation includes a Q&A session with Dr. Choi and our patient expert, Philippa Mennell. So I'd like to introduce to you Dr. Choi. She's a rheumatologist and a clinician scientist at the Cummings School of Medicine at the University of Calgary, as well as a researcher at Arthritis Research Canada. Her research is focused on discovery of biomarkers, which are molecules found in blood and other body fluid or tissues that are the sign of a normal or abnormal process or of a condition or disease. She also works on identifying ways to predict how patients with autoimmune rheumatic diseases will respond to treatments, how to prevent people from developing autoimmune disease, and how to prevent them from developing complications. She leads a research lab and a biobank. Biobanks are specialized facilities to store tissue samples for research. Her background and training include a Master's of Public Health in Epidemiology at Harvard University and a lupus fellowship at the Brigham and Women's Hospital in Boston. Dr. Choi is also the Associate Director of Mitogen Diagnostic Laboratory. So without further ado, over to Dr. Choi.
Thank you, Allison, for the kind introduction. So good morning, everyone. My name is Choi. I'm a rheumatologist at the University of Calgary, and it really gives me a great honor to talk about lupus today for ARC. And I really want to thank you for this opportunity to share with everyone today what I know about the disease and then talk about some exciting research that is happening here at the University of Calgary. And also, I want to thank all the patients who have participated in all the research that I'm doing. And so I'm really excited to be sharing with you some of the things that we are doing right now. These are my disclosures, but none of these affiliations actually has affected the contents of these slides. So when I was initially approached by ARC to give this webinar, they asked me to do these 4 things. So these are the objectives of today's talk. Number 1 is to talk about the symptoms, the cause, and the diagnosis of lupus. The second thing I'm hoping to achieve is to discuss the current and future therapies, and I put in bracket, question mark, potentially a cure for the disease. So that's really exciting. Number 3, to reveal ongoing and new opportunities in the field of lupus research. So that's where I'm going to focus really on what I've been doing in the lab here. And then lastly, I've left a ton of time for question and answer. This is a great opportunity for you to ask me questions and also people questions about anything that we've talked about today. And of course, anything that comes to your mind about lupus and research. So I'm very happy to be spending that time with you today to answer your questions. Okay, so the first objective was to talk about lupus. What is systemic lupus erythematosus? For someone who's doing research in the disease, someone who's been trained to see patients with lupus, I even find it sometimes hard to describe to somebody what is lupus. And I think the reason partly is because it is a very complicated condition. And a lot of the symptoms that my patients have are invisible. So what we do know is that it is a chronic, systemic, autoimmune rheumatic disease that can affect virtually any part of the body. So chronic meaning that we currently don't have a cure for this condition. Is systemic because it can happen, can affect any part of the body. It's autoimmune in that it's your own immune system attacking itself because it's no longer able to recognize what tissue is your own body versus what is foreign, like a bacteria or virus. And then rheumatic disease is just part of, it's a term that generally describes like joints and muscles. But really in lupus, as you can see here in this picture, it can affect any organ. So I have some patients who have lupus in the skin and the joints. They have a diagnosis of lupus. I have some patients who have just purely kidney disease. They also have lupus. Some patients who have brain fog, fatigue, they may have some findings on an MRI of the brain. They also have lupus. So you can see the large spectrum of symptoms, but at the end of the day, they all have the diagnosis or label of having systemic lupus erythematosus. So you can see how challenging it is or can be to make a diagnosis if everybody is looking different. But what we do know that is common is that it mostly affects young women, especially during their reproductive years. There's a 9-to-1 female to male ratio, and as you can see, the age at which it starts is usually in their 30s. Even though lupus is an uncommon disease, like relative to diabetes, heart attack, strokes, high blood pressure, it is an underestimated cause of death, especially among young women. What do our patients die of? Active disease. And so that was particularly a big cause of death 20, 30 years ago when there was really very, very few treatments for lupus patients. Patients died from infections, sometimes from the drugs that they were taking that suppressed their immune system. But more and more, we're seeing patients die of cardiovascular problems. So things like heart attacks and strokes. And those are big complications to get from lupus, especially if you're somebody who's young, female, just starting their career, just starting to start their family. These can be very, very devastating complications of lupus. So delving into the statistics of this, you can see that in this paper that looked at large numbers of female patients. So they said that across women 15 to 24 years old, all causes of death, lupus was ranked number 7. So you can see here, sorry, it's kind of blurry here, but you can see all the different causes of death that they looked at. Lupus ranked number 7. So even though relatively uncommon disease, it's a very, very serious condition that has ranked very high among causes of death for this population. If we look specifically among females who are of Black or Hispanic background, we can see that lupus is the number 5 leading cause. And we know that this disease disproportionately affects patients of non-white races and or ethnicities. So Indigenous, Asians, Hispanics, and Blacks have more severe disease and often worse prognosis. I think part of the reason why lupus is still such a serious disease is because it's so complex that we still to this day do not completely understand why patients are getting it and why certain patients develop more severe features or symptoms. It's a very complex process. What scientists do agree on is it's probably a combination of factors. So there's probably some genetic component to it. There's been a change in your DNA that puts you slightly at risk of getting autoimmune problems. Then at some point during the disease course, you can have an environmental trigger, something that sparks your immune system to then have like a snowball effect that then the inflammation keeps getting worse, and growing. And then the immune system becomes more dysregulated. You produce these antibodies or these proteins in the blood that damages the organs in your body and immune complexes. Again, just part of the immune system that causes inflammation and then causes organ dysfunction. And it is from the dysfunction and the damage of the organs that the patient feels the symptoms. So it goes all the way from starting with genetic risk, there's inflammation in the blood that's building up that causes damage to your organs over time, that eventually leads to hopefully you see a rheumatologist that then makes a diagnosis of the lupus. It's very complicated because all of these different steps contribute in different ways. It contributes differently in patients, and that's probably why we're seeing all the different types of lupus and why certain patients have worse disease than others. Here are some of the environmental factors that have been associated with the development of lupus, and I've highlighted in yellow the ones that were part of my research fellowship when I was at Harvard. So we know that cigarette smoking increases your risk of developing lupus. Interestingly, moderate alcohol consumption actually reduces your risk of developing lupus. Certain hormones, a higher BMI, sleep deprivation, all those things also increase your risk of developing SLE. So how do patients get a diagnosis of lupus? Currently, it is a clinical diagnosis. What we mean by that is it is probably a combination of the blood tests, how the patient is feeling, what their rheumatologist sees on your physical exam. Some patients may end up getting biopsies, getting certain imaging like MRIs, using all of that information together, piecing the pieces of the puzzle together. Then a rheumatologist can call somebody as having this, this diagnosis. There's not a simple blood test or a simple symptom or sign that can definitively say somebody has the disease. It's a combination of all the information put together. So in this figure, I put this arm, this phlebotomy, and this blood test. This is being done right now at the far right of the spectrum. But wouldn't it be interesting if we could actually move that much further, earlier in the time frame where patients can get a much earlier diagnosis based on blood tests alone? Because we do know based on research that the changes in the blood can already be detected even 10 years before patients have symptoms. So we should be really be moving the needle much, much earlier before patients have a diagnosis or have symptoms, and before they already have organ damage or need special therapies or immune suppressants. What if there was a way to prevent this from progressing further to the right? And there's a lot of research right now, some of which I'm part of, that are looking at preventative therapies. How can we find these patients at risk at the first place, and what can we give these patients to prevent them from even getting to the far right in the first place? So that's really, really, really interesting. So we haven't gotten there yet. So lupus is still associated with suffering, disability, and death. But we are trying to get better in terms of the treatment of the disease. And so here is a timeline of all of the different drugs that we are currently using in lupus and when they've appeared on the scene. And so starting in the 1940s and 50s, we had aspirin and steroids that were first approved. Antimalarials, so like hydroxychloroquine, was approved in the 1950s. And then we had some off-label drugs, meaning they're immune suppressants that we've borrowed from other diseases that we've tried in lupus and showed that it works. So that was from like the 1960s to the 2000s. You can see that there's been a long period of time that there weren't any new drugs for lupus. And then in 2011, Benlysta or belimumab appeared on the scene. That was the first biologic to be ever approved for lupus. That was approved in 2011. And then in 2021, you may have heard of voclosporin and anifrolumab or safenilo that was approved for the treatment of lupus as well. So I think I'm going to be showing you this, that there's a lot more therapies on the way. And part of that is, I think, the research that we're doing to better understand the disease. So how do we choose which drugs to give patients? How do we approach the management of lupus? So there are different approaches, different guidelines that suggest similar but different ways of doing it. I'm just showing you one approach. So sometimes rheumatologists will break it down by what symptoms the patient is having and how severe the symptom is. So here is a picture that shows you lupus broken down into 5 general categories. Of course, there are other symptoms that the patient may have. But here they've broken it down to kidneys, the nervous system like the brain, the bone marrow that produces your blood cells, your skin, and then joints. So in green here, these are patient drugs that all patients should be on unless there's a specific reason, like they're allergic to the drug, for example. But all patients should be on hydroxychloroquine, and all patients, especially if they've had severe disease, would have been exposed to steroids at some point. And then in orange, these are first-line therapies, which means that this is the first medication that a rheumatologist would go for. So here CYC is cyclophosphamide, and then you have MMF, which is mycophenolate. Just to give you some example, methotrexate is MTX, belimumab is BEL. If patients fail the first-line therapies, then the rheumatologist would jump on to the second-line therapy, which is in the yellow. And then if they fail those therapy, they would move on to the red, so the refractory disease. I just wanted to point out from 2011 to 2020, again, the only new drug that was added on to this chart was belimumab, which is here under MSK, or musculoskeletal, sorry. Since 2021, we had those 2 new drugs that have now been added onto the picture. So you can see here voclosporin, anifrolumab, and then belimumab was actually added on as an indication for kidney disease. So we're getting there. And I think what's more impressive here is I'll show you at least in 2023, and I'm just waiting for the year end to update this to 2024. But in 2023, there were 148 active clinical trials in lupus around the world. And this is pretty impressive because we have surpassed the number of clinical trials for rheumatoid arthritis. Now, there are different types of clinical trials. So starting off with phase 1. So phase 1 clinical trials are trials that are trying to find the best dose to give patients and what are the side effects. So this is like the very, very early stages of trying a new drug. At the time 2023, there were 30 trials that were actively recruiting patients. And among those, 21 were considered new types of drugs. Phase 2, so once you pass phase 1, you would be, again, checking the best dose, looking more about, finding out more about the side effects to see how it works, kind of like optimizing that drug. There were 65 trials that were ongoing, 48 of which were new drugs. And then phase 3, this is where you know which dose you want to test. You're more familiar with the side effects, but now let's actually try it in patients and compare it to standard treatment or to a dummy drug. So here there are 42 trials that we're actively recruiting, are active, and then 15 new drugs. So this is now we're getting really, really close to getting it approved and to be used in the clinic. So this is very, very exciting. And then this slide is just showing you that from the previous slide, you can see all the different pathways in the immune system that we're trying to target. And you can see it's like a rainbow because we are targeting lupus from all different directions, and you can see how complicated the immune system is. So this you may have heard of in the news. It's called CAR T-cell treatment, and it's supposed to be potentially a cure for the disease. And so this is a picture of the very first patient with lupus who had undergone CAR T cell therapy. She had very severe disease, and they had given her this CAR T cell therapy, and it basically allowed her to be free of the disease, and she was on no medications for her lupus after she received it. CAR T cell therapy is currently, approved for other conditions like cancer, so we're just borrowing that, like we've done for many of our other drugs, borrowing that to treat autoimmune diseases. And now they're trying it out for myositis, scleroderma, other autoimmune conditions. And the way that it works is that they collect the patient's immune cells, in this case T cells, and then they bring them to a lab, and then they engineer them to go back into the patient's body to then attack the bad immune cells. So they're re-engineering the patient's own T cells, re-infusing them to then tell them to find the bad immune cells and attack them. So this is just a way, again, from that study that showed that the patient, she's smiling after she got her CAR T cell therapy, but basically she had pretty severe disease with kidney, she had heart stuff, she had joint, she had the rash, she tried all these medications. Her blood work was very, very abnormal. She had lots of protein in her urine, showing that her kidneys were also affected by the disease. But then after she received the therapy, she was doing well. And so still in the very early stages, we are not in, I don't see it being used in the clinic, in the next few years. They have to undergo those different phases of trial and try on a large population of patients before that we know that it works, and B, it's safe in patients. So we're still undergoing experiments right now. Okay, so the next chapter is to talk a bit more about the future of lupus research. So we just kind of talked about how complex lupus is, and a better understanding is needed to find better therapies for this condition. So one of the challenges with lupus is that it is a highly complex and heterogeneous disease. I don't have one single patient who has the same symptoms, same blood work as another patient with lupus. Everybody looks very, very different, very complex, very heterogeneous. And so when we're collecting data on our patients for research, we're collecting potentially hundreds of thousands of data points per patient. And for a statistician to look at that and try to understand that data point, it can be very, very time consuming and inefficient. And so one of the ways that we've tried to overcome this challenge is to use artificial intelligence. Here I've just put down a paper that I've recently helped write that outlines what is machine learning and how that compares to traditional statistics. What are the advantages of using machine learning? So here I've taken a screenshot of my computer screen with one of the databases that I'm working on, of course, blurred out to protect patient confidentiality, but just to show you the how complex the data sets could be. All these arrows pointing to different directions, because one data point may be related to another data point in a different part of the data sheet, and so forth. All of these data points are interconnected. It's very complex. And for traditional statistics to try to tease out all these potential relationships in the data points may be too overwhelming. So one of the things that artificial intelligence can do is look at all these data points very, very quickly and summarize it in a way that is meaningful for researchers. Some people may, when they say artificial intelligence, they automatically think about robots. They think about the movies that they've watched that talk about artificial intelligence. But actually, artificial intelligence is, there are many different types of AI. The one that we're using for research is called machine learning. So we're teaching the machine learning to do tasks that are normally done by, that can be done by the human behavior and human intelligence, but they can just do it better and learn it faster. So these are just different machine learning calculations or algorithms that we can apply to data sets. And you can see here on the outside of the circle, These are all the different data points that we can gather from patients, and then we can use machine learning to use their algorithms to try to put all that information together into a coherent story to then tell the researcher what is going on. This is a timeline of all the different studies that have used machine learning to study lupus over the years. You can see that there's really been an exponential growth in lupus studies, really in the last decade. Prior to that, there have not been that many studies in machine learning. And I think the reason why we're seeing this large growth is because we have much better computers now that can process large data set. And then number two, as researchers, we're becoming better and better at collecting data and knowing what data points to collect. So in this paper that I helped write, we took a look at these studies and tried to summarize what kind of information we've been able to gather from machine learning over the last 10 years, because that's where most of the studies have happened. We have used machine learning to better understand what causes lupus and how we can better diagnose the disease. We have looked at specifically kidneys, we've looked at brain, we've looked at rashes. We have used artificial intelligence to try to recognize lupus based on brain imaging, kidney biopsies under the microscope. So instead of somebody manually going through the pictures in the microscope, artificial intelligence can scan through that image and then just tell you whether or not the patient has a diagnosis of lupus. So we're really, really getting there. We've used machine learning to try to calculate somebody's disease activity, try to predict whether or not somebody will get a complication from lupus, and also predict somebody's utilization of the healthcare system based on their disease factors. I'm going to show you two quick examples of how I've used machine learning in my research to study lupus. So this is a project that I've collaborated with Harvard. My mentor here, Dr. Karen Kostenbader, who's an epidemiologist there. And what we've done is we have used machine learning to try to create a calculator that doctors can use in their office to calculate somebody's risk of developing heart attacks and strokes. So Dr. Kostenbader has this large database on her lupus patients, and we looked at that and asked machine learning to identify what data points in a patient's chart are the most important in calculating somebody's risk of getting heart attacks and stroke in 10 years. So this is the formula that machine learning spat out, and we are now going to make that available as a tool online for doctors to use. Another way that we've used machine learning is try to understand different subtypes of lupus based on their blood profile. So again, I've collaborated with Dr. Karen Kostenbader here, as well as my other mentors, Dr. Ann Clark and Dr. Martin Fritzler. And you may have heard of the SLIC cohort, which is this large international lupus registry. And so we use their data set and their patient's blood to identify 4 different types of lupus. And you can see here the different colored dots here are the individual lupus patients. And you can see there are green dots, orange dots, red dots, blue dots. These are all different types of lupus. You can see that all the green patients grouped together, the orange is another subset, the red all clustered together at the bottom, and then the blue patients clustered onto the right side. It's very interesting because when you look at these different subgroups of lupus, they have among these different groups, they have different symptoms, they have different drugs that they're on, they have different prognosis. And then we also were able to predict somebody's lupus 10 years from where they are now. So we are able to use that information as a prognostic tool based on which color they belong to. So we are now using this approach to study all types of autoimmune diseases, not just lupus. But I wanted to also point out here that we use blood only in that project, but really you can use that to study urine. You can use it to study fluid collected from the spinal cord. You can use it to study any biopsy, like kidney biopsies or joint biopsies, joint fluid. put all of that into machine learning. The machine learning can then tell you what is the most relevant markers in the blood that you should be measuring in your patients. So this is my lab. At the center of everything that I do, of course, are my patients. And I see patients in my clinic. I am very grateful that many of them are participating in my projects. I send their blood to my lab here at the University of Calgary, where we do biomarker discovery. What I mean by that is we take their blood samples and we try to identify novel blood markers that help with diagnosis and prognosis of disease. We're also interested in markers that can help us follow the patients over the time to see if they are going to flare, and also treatment response. So as they're taking their drug, are there markers that are specific to the drug that they're on that we can monitor to see how well they're doing? We're using artificial intelligence. So I have artificial intelligence students that work in my lab that look at the data that's generated from the biomarker discovery part. And I'm collaborating with researchers at Harvard, MIT, and University of Alberta, and here also at the University of Calgary to understand the information that's coming from the lab. And then importantly, knowledge translation. So this is where we give back to the patients in the community, because all the research that we're doing is important, but what's really, really important is actually giving that information back to the patients, back to the doctors, so they can utilize that information. So I have a whole program in which we take all the research that we're doing and ensuring that that goes back out into the community, and to help with patient education, patient advocacy awareness, and we're doing a lot of that with Lupus Canada. And for other diseases like myositis, we're collaborating with Myositis Canada. And then recently, I'm also interested in doing, I have a couple of clinical trials here at the University of Calgary for autoimmune diseases. And then we're also collaborating with the Global Indigenous Health Office to do research to help improve access to our tests for remote communities. So this is just a slide that shows you we did a Lupus and Learn Patient Research Education Day, giving back to the communities. We invited all of our patients to attend this to talk about what we found out from our research projects that they participated in. This is an acknowledgement slide. My research would not be possible without my research team and my collaborators. Obviously, the funding agencies, and most importantly, the patients who have given their time, their blood samples, to make all the research possible. So thank you, and I'm happy to take any questions.
Wow, Dr. Choi, thank you for the excellent presentation. I know that that takes a lot of time and effort to put together such a wide range of material in a way that we can all understand it. So thank you so much for doing that. Now is our opportunity for the question and answer session. And before we begin, I'd just like to reintroduce our patient expert, Philippa Mennell. Philippa is a member of Arthritis Research Canada's Arthritis Patient Advisory Board, and she's here to share with us her invaluable experience and insights into how these new methods in research and treatment are and may impact the lives of people with lupus. So we are really excited to have you both with us to answer the questions that people are starting to share in the question and answer box. Just before we begin with the questions, Philippa, I think this is the first time that you've heard this presentation. How does this land for you as a patient who's living with lupus and seeing this whole array of information in terms of diagnosis and studies, 148 studies throughout the world, and how machine learning is being used? How does that land with you?
Well, I think it's really exciting in terms of the sort of what you can see in terms of rapid progress that's been made, especially more recently. And I really appreciated your slide, Dr. Choi, that showed like the evolution of treatments and where they fit in a timeline, and also some of the images you presented of like how machine learning has really kind of adjusted the speed of and the quantity of research that's being done in lupus. And I think for any patient, that's just very hopeful. And for myself, I feel that that's very, I feel optimistic about what that means for the future.
Thank you, Philippa. And I apologize if anybody heard any background noise. I have my small dog with me in the office, and she decided to take some large slurpy drinks in the background and then promptly shake herself thereafter and spray water all over the place. So I hope that wasn't distracting for anybody listening. I'm looking at some of the questions in the Q&A box, Dr. Choi, and just starting with the basics. So I'm not going to be asking in order, but more in chronology of what you've been speaking of. So one person is asking, this is a blood test, correct? Is it a standard blood test? Like how are these biomarker blood tests? Can you tell us a little bit more about that?
Yeah, it's a really great question. And sorry I wasn't clear during my presentation. So biomarkers do not just have to be in the blood. It's anything biological. So it can be the tissues, it can be the muscles, the urine. So in that last slide where I showed all the different types of biospecimens, you can call them, biomarkers can be found there.
And is that something that would be done regularly for a patient with lupus? Is this done as a standard process, this biomarker testing?
Yeah, another great question. So the way that I envision it would be we would choose the least invasive biomarkers, like a blood test, rather than, say, having to undergo a biopsy that might require surgery that has risks with that. So for a standard, least invasive, I would say you would need a biomarker test to help with the diagnosis. But I also showed you that slide kind of pushing the needle further earlier in the disease course, that potentially they may be a role to look for biomarkers to identify patients who are high risk for the disease. So you may even get a screening, like a risk test earlier. So there may be a role for that. And then biomarkers during the disease as you're getting treatment would be important. So some patients already are probably getting regular blood tests every 3 to 6 months, maybe even more often if they're really sick. So I think that will still be the case in the future when we find these new blood markers. They're just more accurate, more sensitive tests that we're looking for in addition to what we're doing, and providing maybe even additional information that we didn't even know we could get about the disease. Oh, Alison, you're on mute.
Yeah, sorry, I see that. I was trying to mute the background noise here.
No worries.
Philippa, thank you, Dr. Choi. Philippa, is there anything that you would like to add about the process or that you experienced? Have you had any biomarker testing?
Well, I've had regular testing that would collect samples that could be used as biomarkers, but I've never had any sort of discussion with my rheumatologist that's related specifically to it, like discussing them as biomarkers or as assessment as biomarkers. So yeah, I find this really interesting in terms of what the potential implications for all the information you do collect in your lab work or various tests over the years actually would be. But no, I haven't had discussions around my lab work that looks at, say, what what it
Mhm.
means for my prognosis, how my disease might develop over time, how we might customize treatments. I think that might be happening behind the scenes, but my rheumatologist has not articulated that to me necessarily.
Thank you. Okay, there's several questions about the whys of some of the material that you presented, Dr. Choi. So there's questions like, why women? Why the reproductive years? Why worse for BIPOC populations? Would you like to address any of the why some people seem to be more predisposed?
Yeah, excellent question. And I think we don't have an exact answer yet. We can all speculate based on what we know about the immune system currently. A lot of research is actually association studies, and what that means in layman's term is that we have found there is a relationship. Whether or not it's actually causative, definitively causative, is still blurry. But what we think is happening with hormones is that it probably is affecting the genes. Remember, like we showed that slide with the genetic risk that you need to have some sort of genetic predisposition. But the hormones are somehow, activating the genes that are promoting immune dysregulation. And so, yeah, a lot of my patients are females. A lot of them are just starting to do pregnancy planning. And so there's something in the surge in the hormones, the estrogen, that that may be activating something in their already genetically predisposed DNA that then causes the snowballing effect. It's just it's a trigger, and it acts as a trigger in something that is already going to light up. So that's what we think is happening, and that's why we see that 9-to-1 ratio. And I think that is also probably the reason behind why we see it more often and more severely in some ethnic and racial backgrounds as well.
Thank you. Yes, that covers another question that was asked. What's the association with hormones? So thank you. In terms of the comment that you shared about association, I've heard it explained to me before that a good example of causation versus association versus causation is fire trucks at a fire. There's always fire trucks at a fire. They're associated with a fire, but they certainly don't cause them. And that helps me to appreciate the difference between association and causation. There are a couple of questions about the relationship, and is this an association or a causation? There's questions about fibromyalgia, and there's questions about diabetes being related to lupus. Would you like to comment on either of those?
Yes, so all excellent questions. I generally tell my patients that if they have one autoimmune disease, their risk of getting another disease that's autoimmune related or autoimmune in pathogenesis is much higher. So there's a question in the chat or the Q&A about celiac disease. Definitely, if you're actually the most common comorbidity or second autoimmune condition after lupus, when you get lupus, is hypothyroidism, thyroid disease. So that's very common. So yes, definitely. I think there's a question about diabetes. That was a bit interesting because I think some cases of diabetes and lupus may actually be induced by the therapies that we give them. So steroids, glucocorticoids is another name, or prednisone is another name. Patients with lupus often get high dosages, especially if the disease is very severe. They may be taking it for long periods of time, so they can get diabetes because of the complications of the treatments. So that kind of checks off that question. But yes, one disease, autoimmune disease, leads to another autoimmune disease. We see that quite often.
Thank you.
Okay.
There's also a question about oral health any connection with oral health. And I was wondering if Philippa wanted to, if she had anything to add to that, and then yourself, Dr. Choi. Do you have any connections, experience with that, Philippa?
Well, I think one of the symptoms of lupus can sometimes be like ulcers. So you can have ulcers in the mouth, and sort of lesions that occur around the body affecting different tissues. So I think that can be really challenging sometimes for patients if that occurs as a condition or as a recurrent aspect of their symptoms. Obviously painful and difficult to manage. Yeah, I think that might be one of the other issues are like related to teeth and gum care, and some of the medications actually affect, I think, your oral health as well. They can contribute to like greater gum recession, or like because you're further immune compromised, you can I think be at greater risk of infections in your mouth.
And do you have any
I'm
tips
obviously
or
not
tricks
the
for people
doctor,
with
so
that? Do you have any tips or tricks, Philippa, that you use?
Well, I actually haven't struggled with it too much. When I was first diagnosed, I had greater problems with things like ulcers. But yeah, it hasn't been sort of a major component of my symptoms. So I think probably what I have had shared with me from other patients is there are various oral rinses that can be prescribed, and just general really good oral hygiene. Being careful of infections is obviously a big one.
Thank you. Dr. Choi, is there anything you'd like to add to that?
No, I think, sorry, yes, I do, but I think Philippa raised really, really good points. So I agree with what she said. I think the only thing I would add is another common oral health related symptom that patients get are dry mouth. So they have what's called secondary Sjogren's, which again, this is like the second autoimmune disease thing. But essentially patients have really dry eyes and really dry mouth. And when you don't have saliva to lubricate your teeth that allows you to continue to wash out the bacteria, your teeth are more likely to decay and have cavities. And so super important if you do have these symptoms that you go see your dentist and dental hygienist regularly, probably more often than somebody who doesn't have this condition, just to ensure that you don't develop any infections in the mouth because you have such dry mouth. And they can also make recommendations on what to do to help with saliva production. And there are medications actually we can prescribe to promote saliva secretion. And there are a lot of the other things are more like over-the-counter kind of mouthwashes. Good practices like don't have sugary drinks, making sure you brush your teeth often is really important in patients with this very, very common problem. And then the other thing I can think of would be actually a lot of lupus patients develop osteoporosis. And I just had a patient the other day with lupus on a bisphosphonate drug, so an osteoporosis drug. And they came back and said, oh, I need to have this major dental work done. And patients on this bisphosphonate actually need to let their dentists know that they're on it because they may need to be stopped prior to them going through this procedure. So a very common medication for lupus patients, just to let your dentist know that you're on it, because it could cause a condition called jaw osteonecrosis, which is basically a major jaw problem that can be prevented if you stop the drug ahead of time. So that's the other thing I could think about oral health. Yeah, really, really great question, and things that are actually my patients ask about all the time. So good one.
Thank you. And that leads me to the background tone of several other questions in the Q&A box are about those conversations with your doctors. So I wonder if there's anything you can share with participants today and those that will be reviewing the recording as well about how to have those conversations about, should they be having biomarker testing? How do they access, if they're interested in finding out the results of that, or contributing to clinical trials, or like having that conversation with your doctor about your own particular situation. People are sharing in the chat box about, they have a number of other conditions, and how do they have these conversations with their doctors? Are there any general tips that you can give us that way?
I'd be interested in hearing from Philippa's point of view and her experience. And I can add to that too.
Yeah, I feel like for me, I've had lupus quite a long time, and I feel that in really recent years, the conversation has kind of shifted a little bit in terms of what I want to ask my doctor and what I feel I would like back in terms of opportunities to participate in trials or to find out about what information might be available to me as a patient. Previously in my treatment, I feel like it was very trial and error. We've just sort of, I've had certain symptoms, different symptoms have arisen over the years, and based on how I was doing, we've tried to treat. And when certain things haven't worked, we've tried a different treatment course. And that has, I feel now kind of, there's an opportunity to shift that conversation a little bit with more information being available about the kinds of lupus that you might have, the kinds of antibodies that are in your blood, the kinds of medications, because we now have more options that may be more suitable to you and your condition. So it's interesting that I have been approaching my rheumatologist more in terms of asking for more specific information about what my biomarkers, I guess, look like. I've just asked in terms of what do my blood panels look like? What do my actual, like, what antibodies are present for me? And and how do certain treatments, how effective are they in treating people who have my kind of antibodies or the kind of symptoms that I've been dealing with, and trying to treat more effectively that way. So I guess that's kind of how I've been approaching those conversations, but I think it'd be really interesting to hear more about, like, from Dr. Choi, about how she sees those conversations developing in the future, because I feel we're in a sort of transitionary period right now.
Yeah, thank you, Philippa. You integrated so much of what Dr. Choi was sharing in her presentation about how there's these different types, and and everybody is different. And that really, the conversation will be individual between the rheumatologist and the patient. Dr. Choi, over to you.
I agree with Philippa, and I think that the conversation is changing. I think you should have these conversations, and the rheumatologists are connected with, I guess you can call them lupologists. I like to call researchers at a nearby center who are doing research and are happy for patients to participate. So that's actually how a lot of my patients are being referred to do research, is through their rheumatologists. And everyone's really supportive, collaborative. They want research to happen. Patients who approach the rheumatologists get referred to our lupus center to participate in trials. And so there are, I think ARC has a great website of all of the research scientists who are also doing lupus research with contact information. So you can reach out to the individual investigators who can then also provide you with more information on what they're doing and how you can participate. So there are lots of different avenues, and I totally agree with what Philippa said about approaching your rheumatologist first if you don't know where else to go. That we all work together as a team. We all go to conferences together and talk about it or share our exciting research. So I think it's a new way of approaching research now.
Thank you. I think this collaboration within the rheumatology community is stellar. And so you've addressed those questions together, not only about the conversation with your own rheumatologist for your own care, but the conversation with your rheumatologist in terms of finding out about what trials you might be able to participate in. Philippa, were you going to say something else? I'm sorry.
I was just going to add that if you feel like you sort of haven't had that conversation with your rheumatologist previously, or if your particular rheumatologist isn't perhaps that involved in research directly or hasn't shown that much interest in enrolling you in trials or whatever, I think worth bringing up the conversation and just sort of asking them if they aren't particularly knowledgeable or interested in an area that you are, if they could refer you, or if you could seek that out with another rheumatologist or another researcher, and if they would support you in that, because I think you'll find that you get really good feedback. I have done that in the past with my rheumatologist.
Wise words. I'm reluctant to bring this session to an end because it's such a great conversation, but it is the end of our time together. I know that there are other questions and great questions in the Q&A. Don't worry, because we always address these questions that weren't answered in the session by answering them on the webpage, on the Arthritis Series Education Series site for this topic. So any questions that weren't addressed during this conversation, we will add them to the question part of the web page. So please do check it later. I really want to thank Dr. Choi and Philippa for sharing with us their expertise, both in as clinician and researcher and with lived experience as a patient. I want to thank all of our audience for joining us today. And please do stay on for a few minutes after I finish speaking, because we're going to show a video from this episode. I'd also like to thank Arthritis Research Education Series sponsors for their support: AbbVie, AstraZeneca, Biocon Biologics, Fresenius Kabi Canada, JSK, and Biogen. And for all of you that haven't had the opportunity to visit our website and check out the Arthritis Research Education Series, I encourage you to do so at arthritisresearch, all one word, .ca/learn. We've lots of episodes on a variety of topics that you can look at in your comfort of your own time in your own home. So now we're going to play this video for you, and it's about 5 minutes long. Thank you to everyone for joining us.
I think we've gotten a lot of information about what causes lupus over the past several decades, but ultimately we don't fully understand what we call the pathogenesis. What is the mechanism of that causes the disease? So hopefully my research will help us better understand what is the underlying cause. So lupus is a chronic autoimmune condition that leads to widespread inflammation in the body that can cause organ failure or organ dysfunction. So we know that there's more to it than just genes. So some of the things that we think are important in triggering the immune system to behave this way would be things that are out there in the environment. So that would be exposure to UV rays, certain chemicals or air pollutants. Smoking has been associated with increased risk of developing lupus, obesity, as well as sleep deprivation.
My name is Philippa Mennell, and I have lupus. And I was diagnosed when I was 21, and I've had it for 23 years. I was in my third year at university. I started to develop some muscle pain, joint pain, and when I went to get treatment for it, it was thought to be just stiffness associated with being tired and studying for exams and things like that. But it kept progressing, it kept getting worse. Eventually, I had very swollen joints and couldn't move. Fortunately, I had a GP who had recently seen a lupus case, and he was very alert to it and ran all the tests, and yeah, it came back as lupus.
So one of the research passion of mine is looking for biomarkers that can help us with an earlier diagnosis of disease. Biomarkers in a general term means basically any fluid or tissue in the body. You can find molecules that we are looking at whether or not they're helpful in helping us make diagnosis. So what I mean by that is that there's been research to show that even before patients get diagnosed with lupus, you can find these molecules in the blood even a decade before. And so if we can find these biomarkers in the patients and counsel the patients about things that they can do to prevent disease, or give them some ideas to what is their risk of developing a disease like lupus, I think that would be really informative for the patient. Making an early diagnosis is also important because then we can initiate treatment that would then prevent them from developing damage to their organs that in many, many cases is irreversible.
Initially, when I first received the diagnosis, I was really scared. The only other sort of instances of lupus that I'd ever heard of were really remote cases for me. I didn't know anyone in my immediate world who had it. I think it was hard for me at that stage because I was almost finished university, and there was some question as to whether I could go back. There was some question as to whether I could finish. All my plans kind of changed based on what I had intended versus what I might now be capable of doing and how my life had to change.
My lab is a special lab that is able to discover new biomarkers, and we're able to develop tests for that. We also have a dry lab where we're then able to take those biomarkers and use machine learning to try to understand what are the roles of these biomarkers. So one of the things that we did recently is that we did some biomarker tests, a very comprehensive list of proteins. Some of them are novel, have never been looked at in lupus, and some of them more established, so things that your doctor would order if you have a diagnosis. And we tested it on over 800 patients with lupus, and these patients had blood taken at diagnosis a few years later and then 5 years later after they were diagnosed, so repeated tests. Based on just the blood test alone, we were able to identify 4 different types of lupus patients. And it was very interesting to see that these patients not only looked different, but their prognosis was different.
I think this research is really exciting. I think the idea that you could have a bit more of a focused understanding of how lupus might be working in the body, what the mechanisms are that are actually, ultimately causing the disease or even triggering disease flares or particular kinds of symptoms is really exciting. More practically, maybe my hope is that we find therapies and practices and methods that improve the quality of life of people with lupus and arthritis in general.